Hello everybody, my name is Melika Kalantari and I'm a PhD student at University of Reading. My PhD aim was to understand patients' journey with achalasia, which is a rare condition, try to co-design an intervention with them to change their eating behaviors and also to pilot the co-designed intervention. I've been doing this with my PhD supervisors at University of Reading, Dr. Amelia Hollywood and Dr. Rosemary Lim, and my clinical supervisor, Mr. Majid Hashemi. So what is achalasia? Achalasia is a rare motility disorder affecting the esophagus. Its prevalence rate is 1 in 10,000 people. It's where the esophagus loses the ability to move food and drink along to the stomach. It's a chronic condition and it doesn't have a cure. As you can see in the pictures on the left, you will see a normal esophagus and an esophagus of a person with achalasia. In the patient with achalasia, the lower esophageal sphincter doesn't relax, therefore you get the esophagus that dilates and it has the muscles that doesn't relax. The signs and symptoms of achalasia are difficulty swallowing, regurgitation, chest pain, and weight loss. Achalasia can be diagnosed by the clinical history of a patient, barium swallow, which is a liquid that creates a bird's beak under the x-ray. You can see it on the picture on the right, endoscopy, and manometry. Symptoms of achalasia can be treated by medications such as calcium channel blockers, dilatation, which is a balloon that dilates the esophagus, Botox injections that help to relax the muscles, surgery, and non-medical interventions. Treatments only alleviate the symptoms of achalasia, and people often need multiple and repeated treatments. Even after successful treatment, people need to manage their condition with long-term self-management. And people usually experience different kind of symptoms after treatment, and one of the common ones is reflux. In the first part of my PhD, I have explored patients' experiences and I wanted to understand what patients go through from before diagnosis to after diagnosis. And we developed a process map on patients' journey. And as you can see, the process map divides into two phases, which is before and after diagnosis. There are many steps involved in patients' journey, and what I would like to highlight, and that's a paper I published on the experiences of people with achalasia from initial symptoms to long-term management of the condition. And what I would like to highlight is that even though people go through many steps to receive a diagnosis and receive a treatment, they still need to go back to where they started and self-manage their condition like they did before they got a diagnosis. And even though they try different treatments and different self-management strategies, their symptoms do not always improve with self-management, and they need to be in this loop of self-management and trying different treatments to get some relief from the signs and symptoms they experience with achalasia. There are so many long-term challenges with achalasia, and there are some eating behaviors that are very challenging for people living with achalasia in their ongoing management of their condition. And these are some of the long-term challenges that people mentioned in the first study. And those included time of the meals, the portion size, the types of the food they eat. A lot of people avoid to eat a lot of food, and a lot of binge eating and eating in public and or with other people was one of the long-term challenges with achalasia. The aim of our study was to co-design an intervention with people living with achalasia to address one of the most challenging eating behaviors they experience in the long-term management of achalasia. We decided to do that by having 4 virtual focus groups with 6 to 8 people in each group. We recruited the participant through the Achalasia Action, which is an independent charity supporting people living with achalasia in the UK. Participants were presented with the effective behavioral change techniques and they discussed what resonated the most to them. In the first focus group, participants prioritized the most challenging eating behaviors from the list that was presented to them. In the second group, they discussed the co-design intervention and chose the best delivery method for that intervention. In the third group, they discussed the intervention again and they confirmed the delivery method of that intervention. And in the fourth session, participants gave their feedback on the co-design intervention, which was a workbook. We have decided to use a theoretical framework for our study. And the theory that we used was a behavioral change wheel, which consists of 3 layers. At the core, at the hub of the circle, we have the behavior that causes a behavior and maintains that behavior. Then we have the intervention functions in the middle layer, and also the policy categories that identifies and support the delivery method of the co-designed intervention. There are currently 93 techniques divided into 16 groups. We have reviewed other papers on changing eating behaviors in different populations, and we have identified the effective techniques in changing eating behaviors in those populations, and we have presented them to our participants. As you can see in the model, in the combi model, for a behavior to be changed, an individual needs the capability, motivation, and opportunity. There are activities within each element of the combi model that enables an individual to change their behavior. Within the capability element, we have feedback and monitoring, which is giving instruction on how to perform a behavior and having feedback on that behavior. And also shaping knowledge, which involves gathering information and knowing more about that behavior. Within the motivation, we have goals and planning, which involves action planning, and also social support, which is getting help from family, friend, or somebody that is familiar with the condition. And within the opportunity, we have the antecedents, which is restructuring the physical and social environment, and regulation, which involves regulating negative emotions and managing stress. We had 24 participants for our study, 21 female and 3 male. The age range of our participants were from 29 years old to 77 years old. We had 8 participants in each group, and for the final session, we asked the participant in the previous session to take part and give feedback on the workbook. All 24 participants have already attempted to change their eating behaviors in the past using different activities and techniques. So within the capability element, people suggested that making a daily food diary and reflecting on it later can be very useful, and shaping knowledge was just reflecting on the situation and learning from it and creating more knowledge about a situation. For instance, if eating in a social setting can be stressful for them, they will just write a note or write it in their food diary, and they can reflect on it later and just create more knowledge around that area. And within the opportunity element, changing social and physical environment. For instance, if they're sitting down and they're stressed or they can't eat, they would stand up or they would go out of the room to change the environment. And it will be body changes. If some people are not comfortable eating while they're sitting down, they would stand up and they would alter their body position in order for them to be able to eat while they are in a social setting. And within the motivation, there are goals and planning and social support. And within the goals and planning is to identify triggers and trying to remove those triggers for future. So they plan that in future, if they're eating in a social setting, they know what things can trigger and their symptoms, and they will try to plan and avoid them. And also social support, which involves speaking to others, sharing tips, or just talking about the situation and getting some support from family members, from somebody else that has the condition, or a friend or a buddy. So the co-design intervention is a workbook that is available as a printed copy and online, and people can download and print it. A lot of people living with achalasia wanted the workbook to be editable, so they can add content or remove content from it depending on what they need. The workbook has different chapters based on different elements of the COMBI model, and it starts by quotes from patients, which are activities that other people tried, and then it has activities for people that are using the workbook to complete, and they can come back to it at any time, reflect on it, and they can just tailor it based on their needs. We have used a theoretical framework for our study, which is very important and beneficial in intervention design. Using a theory can summarize the known evidence, and it can allow communication across the research group. It can also be used as a starting point to identify what needs to be changed. We have collected qualitative data using focus groups. Hence, we have rich data coming from people living with the same condition. With qualitative data, you usually have smaller sample size. And the smaller sample size allow us to collect data that are more representative of that group. However, they're only representative of this group and cannot be generalized to a wider population. We have recruited our participants through Achalasia Action. Therefore, they were all diagnosed with achalasia and are part of this group and have been exposed to the same information, same resources, and same support channel. People's experiences that can be different if they are not part of the achalasia action. The participants in our study were recruited from the UK, and if we recruited participants or patients that are not living in the UK, we could have people that have slightly different experiences through their diagnosis pathway and their treatments that they receive in other countries. In conclusion, we believe that this method allowed people with similar condition to co-design an intervention to tackle one of their many challenges that majority of them find challenging. And people discussed what works best for them, and they came up with suggestion, ideas, activities that will or might work for majority of them. And then the developed intervention, the workbook, can be used as a tool for everybody to use on their daily life, and they can tailor it based on their needs. And we're hoping that in the future we can pilot the co-design intervention and also test its effectiveness to just see if it was useful or not. Thank you so much for taking the time to listen to my presentation. If you have any question or comments on this presentation, I would be more than happy to answer. Please contact us directly and we will respond. Thank you.